So these are the 5 major types of the stones. Xanthine we can avoid. It's a very, very rare kind of a stone. Deficiency of enzymes and xanthine oxidase. But these 4, in fact, these 2 are the most common. Sometimes you get questions on uric acid and cysteine. There are 2-3 questions, but broadly the questions are based on the first 2 types. So first is calcium oxalate. First, the most common renal stone. Okay, most common stone to cause hematuria. Maximum hematuria, maximum risk is with calcium oxalate. Why so? Because the shape of it is spiky and irregular. Because of spiky nature, it causes more damage to the mucosa, the lining of the pelvic ileal system and the ureter, and causes hematuria. Okay, easy to understand. Okay, now the nature and the characteristics. See, calcium. This also has calcium. So, radio opaque, hard. So, we'll talk about every stone, these 2 features. Which stones are hard and radio opaque? Right. So, here only I'll specify the soft and radiolucent is uric acid. Soft and radiolucent. Rest all 3 are radio opaque and hard. So, 1 point is gone. Okay. Oxalate, phosphate and cysteine, they are radio opaque and they are hard stones. Uric acid stones are soft and radiolucent. Hard stones, radio opaque stones will be visible on X-ray, common sense, you know it. Uric acid, pure uric acid stones are not visible on plain X-ray because they are radiolucent. Okay. Okay, back to oxalate stone. Radio opaque, hard, they precipitate in acidic urine. Right. Now, this urine concept also I'll specify. Okay. Now, acidic urine, acidic urine, acidic urine. The only stone, phosphate, precipitates in alkaline. Right. So, 3 radio opaque, 1 radiolucent. So, radiolucent is uric acid. Remember it this way. Otherwise, you will get confused. Again, nature of urine, 3 acidic, 1 alkaline. So, remember the odd one. Okay. The only radiolucent is uric acid, pure uric acid. The only stone that precipitates in alkaline urine is phosphate stone. Rest all precipitates in acidic urine. Okay. Now, calcium oxalate monohydrate. One subtype of calcium oxalate stone. This is extremely hard. Hardest of all oxalate stones. So much so, it becomes resistant to ESWL. Extracorporeal shockwave lithotripsy. We will talk about it. There are 2 stones which are extremely hard and resistant to ESWL. Other is cystic stone, cysteine stone. Cysteine stone, I do have a question probably on this. Cysteine stone is extremely hard stone and it does not get broken by ESWL. Rest stones will get broken by different ranges of ESWL. Okay. So, most of the info we have covered about oxalate stones. Right. I'll not go into details of dietary factors because the 2 most important causes of renal stone formation is the diet, less water intake, diet rich in oxalic acid, diet rich in the uric acid, means that produces more of uric acid in the urine. Right. So, diet is a significant factor. And then less water intake. So, urine is concentrated. Urinary infection is a significant risk factor for the renal stones. Okay, so that is common for all stones. Okay, so now the phosphate. Most of the questions are about the phosphate stones. There are many questions, right? Phosphate stone, radio opaque, hard, alkaline urine. This I have already explained. Now, phosphate stones can be single phosphate, that is calcium phosphate. Mostly, they are combination of three phosphate salts: calcium, magnesium, ammonium phosphate. That is another question. This combination you have to remember. I do have a question on this also. Calcium, magnesium, ammonium phosphate. That is why we call it triple phosphate stone, as mentioned in the previous question. This is also called struvite stone. So remember this term also. Struvite stone is triple phosphate stone. Now they precipitate in alkaline urine. Now the most common stone associated with infection. That's a previous question. I've already told you. Which infections? Proteus is the one of the most common infections. Klebsiella, staph. They release enzyme urease that splits urea into ammonia. Ammonia makes the urine alkali and the stone gets formed. This is the reason. So if you know this, then you will not forget that phosphate stone specific. So most common stone associated with infection, most only stone that precipitates in alkaline urine. And last characteristic of struvite stone, triple phosphate stone, is it doesn't form a small, round or a spiky stone like oxalate and other stones. It forms a big stone. They grow to large extent and they will grow to cover. I'll show you in the other pictures also, right? There are lots of questions which are image based. Kidney is one of the commonest areas where you will get lots of image based questions. I'll try to show you as many images as possible, right? So that's a kidney and that's a pelvic ileal system. So it starts in the pelvis. Suppose a small stone keeps growing, keeps growing, keeps growing, keeps growing. It fills up the entire pelvic ileal system. So keeps growing, growing, growing and fills up the entire pelvic ileal system. And this is called staghorn calculus. All of you know about it. Very popular term. So you should know what is staghorn. Staghorn is a triple phosphate. Staghorn basically means the shape. It like the horns, right? So it fills up the entire pelvic ileal system. The most difficult stone, and because of the entire system is obstructed, right? This is about oxalate stone. Now the cystine stone. I've already told you about the most important question about cystine stone is extremely hard, radio opaque, acidic urine. Again, these points I've already told you. So this is also most resistant to ESW. Okay. Cystine stones basically seen, they are rare stones. They are seen cystine, you know, it's an amino acid. So metabolic errors of amino acid metabolism. So cystinosis, when excess of cystine in the urine. Uric acid, all of you know, red meat eaters have excessive uric acid production in the urine, not in the blood. Uric acid, the most important question I have already told you, soft and radiolucent. So not visible on plain X-ray. So they can ask you which of the following stones is not visible on plain X-ray. And they are most responsive to ESW because they are soft, they'll be easily broken. Oxalate and phosphate stones also get broken, except calcium oxalate monohydrate. But uric acid most easily get broken. Okay, so this is about the stones. Which of the following best describes a composite struvite stone? So magnesium, ammonium and phosphate. If calcium is also given, so that can also be added. Calcium phosphate, magnesium phosphate and ammonium phosphate. Okay, so this is just the anatomy. This I kept to show you the staghorn calculus. Now the images. See, that's a stone. The entire pelvic ileal system. This is stone. The whole of it is packed. Now this is the real picture, image based question. These will be given to you in your exams. Okay. and how to pick the correct diagnosis. There are many other confusing diagnoses. One of the most important is putty kidney. I have a question in the end, I'll tell you. So that's a stone after being removed in total. So that's a stone, kids. See the shape. So this is plain X-ray showing you the stagon calculus. Another stone in the left ureter, and this is bilateral stagon calculus and left lower ureteric calculus also. So these are the total findings. So image based question, very, very important. Okay. Now with regard to renal stones, which of the following statements is false? We have to look for the false. We have already seen most of the characteristics. The common bacteria found as a nidus for renal stones are staph infection. Yes, we have already seen. So this is true. If parathyroid adenoma is found to be cause of renal calculi, it should be removed before the treatment of calculus. All of you know hyperparathyroidism. Hyperparathyroidism is a cause of renal calculi because of excessive calcium. So if there is hyperparathyroidism, it should be treated before the urinary calculi, right? Because you have to remove the source of the calcium first. Pure uric acid stones are radio-opaque. So that's a false statement. Stagon calculus is composed of calcium, magnesium, ammonium. So this is right. So now you can answer any question based on the information I gave you about the renal stones. Which of the following statements are false? So multiple correct statements. So let us see. So in these kind of questions, you need the information. You cannot just use your tukka, right? You can just by chance, you can pick any choice. Okay. So no role for confusion in these type of questions. So renal stones are usually visible on, so more than 90% are radio opaque. So true. The severity of pain of ureteric colic, that is ureteric stone, is related to size of the stone. False. In ureter, even a 4 millimeter stone can cause significant non-bearing pain, right? Whereas 7 or 8 millimeter stone patient may not have that much of pain. So intensity or severity of the pain is not related to size of the stone. Hydronephrosis, pyonephrosis with the palpable swelling is common. False. It is not very common. It is seen. Hydronephrosis can happen if the ureter is completely obstructed. Stagon calculus, pelvic ileal system is completely obstructed. Pelvis is completely obstructed. So complete obstruction anywhere in the urinary system can cause hydronephrosis. But this is not very common. Not every patient will have significant hydronephrosis. And that too, so much so, only grade 4 hydronephrosis, I'll tell you, I do have a question on hydronephrosis. Only a grade 4 big hydronephrotic kidney will become palpable mass. So that's not very common. Hematuria is common, true. Very few physical signs, true. Mainly symptoms, pain, sometimes fever because of associated UTI, right? Sometimes vomiting because of reflux. Okay, so this is about the renal stones. Now, this also we have already. ESWL is contraindicated in cystine stones, most hard, so resistant. Plus another repeating again, calcium oxalate monohydrate. So not all oxalate. Majority of oxalate stones, they will get broken by ESWL, but only specific subtype. So, right. Now we'll talk about the treatment of. Let me cover the other aspect of renal stones. Next, some questions will be based on the management of renal stones. That's another critical area. Types of stones, their features, their causes, right, their shapes and everything, and the management. Investigations also broadly, let me summarize here. For stones, initial investigation of choice is plain X-ray. Best overall is NEET. Remember, we don't need a contrast for stones. We need a contrast only when we need to see the excretion of kidney. If you have a doubt about the functioning of the kidney, excretion part of the kidney, right? Otherwise, plain CT scan, non-contrast CT scan is good enough for seeing the stone exact size, exact location, and you can proceed for the treatment. Okay. Third is IVP or IV, intravenous pyelogram or intravenous urogram, where you don't have the facilities for CT scan, you can go for IVP. IVP again, both anatomical and functional assessment of the kidney. It will also give you an idea about the excretory function of the kidney.